Assalamu alaikum. Welcome everyone on board. Today we will just try to discuss this topic of scoliosis. Yesterday we started these rheumatological concerns. So, um, Noon, have you read about this topic of scoliosis?
Sorry, sir, your voice got interrupted, sir. Again, sir, please.
Have you studied this topic of scoliosis?
Sir, I didn't refresh it, but I studied in past, sir.
Okay, just to start, what do you think? What are the concerns in a patient undergoing this scoliosis surgery?
Sir, start with the preoperative assessment of the patient, sir.
Hmm.
In preoperative assessment, we will get some basic baseline investigations along with some imaging.
Okay,
In
right.
imaging, sir, we need a cervical X-ray, cervical spine X-ray, sir.
Okay,
Then, sir, in baseline investigations, we will need, sir, CBC.
okay,
And then, sir, after these imaging, will check the pre-op assessment, clinical pre-op assessment,
okay,
airway assessment, sir.
okay,
Then, sir, systemic examination, cardiac, CBS, respiratory. These are the major ones.
hmm. What else?
Else, sir, then this, sir, I think, sir,
What
अभी
do you
सर यही
think?
recall हुआ सर.
What are the an important point with reference to uh, uh, this scoliosis, which are important for anesthetist?
Sir, neuro examination, sir, before surgery and after surgery, sir.
Okay, so actually,
Sensory and motor.
I just will tell you just a second, please. Actually, whenever some this question about concerns, so actually what you should be knowing that like of course evaluation will be one thing, but the patient coming for evaluation for scoliosis mainly will be in two groups. One which is congenital, okay, and one which is acquired. So this is the main group because kyphoscoliosis is the abnormal curvature of spine. So if it is congenital, some other congenital anomalies can be there, and because when the thoracic cage is not built properly, the lungs which are being yes, the lungs which are still in the maturation phase will not be able to develop. So in congenital, uh, the lung maturation will be a bigger issue as compared to acquired. Acquired may be mainly, for example, you can just with any traumatic, idiopathic, or any neuromuscular disease. Okay, so just broadly you can uh, accordingly. Okay, so now you can expand your answer that you will be looking at the main cause of scoliosis, any other associated anomalies or any other associated problems, or if it is idiopathic or if it is neuromuscular. So neuromuscular disease which is leading to this scoliosis will be another concern for you. Okay, so in this way, and then you will the next thing will be that severity of scoliosis. So severity, you will have some radiological studies, and by radiological studies you will know this Cobb's angle. Okay, this is one thing. Now the other thing will be related to the lung maturity or lung problems. Okay, so lung problems like restrictive lung disease pattern. Okay, and so you will be doing some PFTs, chest X-ray. Okay, and the X-ray of the spine. That will be so severity. And then, of course, if it is severe disease, so whenever there is restrictive lung disease pattern or a congenital then pulmonary hypertension can be there. Okay, and the rest of the thing will be according to the scenario, like according to what is the etiology. Okay, and then you can expand your answer. I'm just giving you a bird eye view, and then we will see in the text that what are the things which we can think about. So so etiology, what are the severity, what systems are involved. So and then if you talk about intraoperatively, so mainly intraoperative things which should be thinking. Of course, we will come back to evaluation. What I'm just trying to tell you what are in. So you prone position, one thing, hypotensive anesthesia, another thing, uh, neuromonitoring. Okay. And previously, traditionally, they used to have this wake up test. So they can still ask you about it, but hypotensive anesthesia, neuromonitoring, and whenever there is hypotensive anesthesia, so in this, so neuromonitoring they are doing, and still there may be AKI, okay, positioning related problem, prone position, as I told you, and uh, concerns related to TIVA and TCI. Okay, and usually this is a staged surgery a number of times. So then you can expand, and of course, post-operative care with you have to think about. And Bilal, would you like to speak out? Are you able to speak today? Are you free? Bilal, can you hear me? Okay, okay. So you can uh, write in text if possible. So we will just try to expand on what I discussed. So here we go. So preoperative evaluation with reference to pulmonary, cardiac, and neurological comorbidities. Okay, because in this there may be some neurological involvement. So exercise tolerance, respiratory function, and then the Cobb's angle, as I told you. So measurement of Cobb's angle, pulmonary function test with reference to this FE1 or FVC ratio we have discussed recently. So this is the upper curvature, and this is the lower. And that's how you.
I have to talk to you. I never touched her. She repulsed me. What? What? Jen, what's wrong? It's over between me and Dick. Oh,
So that's how you can measure the Cobb's angle. This they can ask you still. If Cobb's angle is high, there is more morbidity associated with it. And pulmonary function test, as I told you, there you see, uh, until the curvature reaches 65. However, in patients with congenital neuromuscular causes of scoliosis, pulmonary dysfunction is likely to occur at lesser angles. So that is what that whenever there is a congenital anomaly, the, if it is congenital, this is, choice of paralysis is of, can you keep yourself mute, please? Because this is disturbing me. Functional capacity, echo, use of thromboxane, very good. Uh, okay, just a second. I will just explain. So as I just told before, that if there is the scoliosis congenital, not only other congenital anomalies will be there, the severity of lung maturation or lung problems will be more. There will be more restrictive lung disease pattern, and it will be leading to airway problems as well as sorry, ventilation problems as well as pulmonary hypertension. So you have to think about it. So and also if there is neuromuscular disease, there are chances of cardiac problems, like for example in Duchenne muscular dystrophy. So there are cardiomyopathy, dilated cardiomyopathy. So not only if it is not associated with neuromuscular disease, still they can have cardiac effects because of pulmonary problems. Okay. So because there is pulmonary hypertension, restrictive lung disease pattern, and the comorbidities which are there. Okay. So okay, so you will just analyze all these things, and then you will see that what is the severity. And usually, sometimes they are doing in stage surgery, or sometimes they are doing total correction. Okay. And another, where we will just discuss about neuromonitoring and this preoperative preparation is never an emergent operation to optimize patients. This is of most benefit in patients with significant comorbidities. They have written some anemia correction, uh, cardiac function if it is correctable. Mm, There are some surgical concerns. Okay, so in this patient, the things which you should be knowing, that all the concerns with reference to prone position. So anyone want to speak out about prone positioning? Because there are so many concerns with reference to prone position, that there are optic problems, like problem in eyes, not only because of hypotensive anesthesia, but also the eyeball is hanging. So if the patient already has some retinopathy, uh, or the patient is having hypotensive anesthesia. And third thing, which as Bilal mentioned, because a number of times thromboxane is being this sorry transdynamic acid is being used. So transdynamic itself acid itself is one of the cause, because microthrombi which are cleared by the circulation sometimes are not cleared in with this microthrombi. And this is one of the differential diagnosis of post-operative blindness, which can occur in these groups. So when you are using tranexamic acid, this is something which you have to taking care of. Maybe even a patient who is going for scoliosis surgery, maybe you can have a baseline ophthalmology and assessment if the patient has some recent this retinal surgery. So this is something which you have to consider, because maybe it is not advisable to proceed with the scoliosis surgery in these patients. Okay. So another thing which you feel in prone position, the rest of the things you have to take care of the genitalias, you have to take care of the breast tissues, you have to take care of the joints, all the pressure points. Okay. And
Endotracheal tube position.
sorry,
Sir,
proper.
proper endotracheal positioning, sir, and IV lines.
Yes, arterial line, of course, in this scenario, because in prone position, it is difficult to take IV lines. It is difficult to do blood gases. Okay, so it is a number of time, and because in this case they are also doing this hypotensive anesthesia, so it is always advisable to have intraarterial blood pressure monitoring. Okay. So this is one part of it. So you have to take care. Abdomen should be free, and traditionally there is a table in which the abdominal there is opening. So actually, abdomen is hanging through it. Okay. So take care about it. Now, one question which it is associated in this position, that, for example, if you are having a surgery in a prone position, okay, this and your endotracheal tube is dislodged. Okay, so what will you do? Yes, Noon.
Yes,
Mask
sir.
ventilation.
Tube can dislodge, sir. Secretions can sir, block the ATT tubes. And sir,
No,
most important, sir,
no,
throat pack.
response.
We will do the throat packing, sir.
No, 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 no. You are not understanding. I repeat my question. You were doing this surgery in prone position, and the endotracheal tube is dislodged. It has come out. What will you do? So mask ventilation, you can try
Stop,
for
sir.
supraglottic airway device. Okay. Then Of course, fiber optic, intubation. So these options you will have. Of course, the immediate response should be airway, breathing, circulation, call for help, immediate inform. Because remember one thing, in the places where this surgery is not being done in the proper table, things are a little different. But you, like for example, flipping will not be an easy option. So in that, if they are asking you this question, airway, breathing, circulation approach, you will try to have mask ventilation, you will try to put supraglottic airway device, so fiber optic, and if even you can try it for an intubation, which will be very difficult. Just imagine the prone positioning. So this is a question which they can ask you. So this is one thing. Then the next part of the question, now you have developed a cardiac arrest. Cardiac arrest in prone position. What will you do? So again, it's a very challenging situation because it's very difficult to do the massage in prone position, but still, uh, because and another thing is that it is difficult to flip the patient. The patient is wrapped. If you just open in Google, you can see the picture of how is the patient positioning in scoliosis surgery with the proper table. I don't remember the name of the table. There is a proper table. Anyways, so at that time, like they can ask you that you will try to do the massage in prone position. The next problems, or sorry, things you can do, that you can make bring the patient in the you will have to put the patient out of flips and maybe on the floor, or maybe you will bring another table on which you can do the massage. This is one option. The other option will be that maybe there is an open cardiac massage. If things are going down, so they can open the thorax and they can do the open cardiac massage. Okay. So these are few options which you can use if you have a arrest in prone position. Of course, we can just pray that we don't face this situation, but it can be a very, very serious problem. So if this question is being asked in the exam, the possible options will be like that, because there are certain answer for a default answer, which you can say airway, breathing, circulation, call for help, and you will evaluate the situation, and then these are different options which you can answer. Okay. So this is a question which they can ask you. In this also, there are a lot of chances of bleeding. Okay, so as I mentioned, that hypotensive anesthesia, you can think about it, and of course you will be using it. Then there will be TIVA. We will just try to have few words about all this hypotensive anesthesia, TIVA, and then cell saver. Okay, any patient in which you are expecting a lot of bleeding, you can have use of cell saver. Then another another thing in this things which you have to be concerned, then evoke potentials. Okay, evoke potentials or neuro monitoring. So the concerns, I will start from evoke potential, because there is a special department, a special team, which is neurophysiology. Okay, of course, and in our country, maybe still in some centers may be available, but it's not available everywhere. So neurophysiology, they are doing the proper work potentials. So now you cannot use inhalational agents. Okay, you cannot use muscle relaxant. Okay, and you cannot use anything which is affecting the motor work potentials, the somatosensory evoked potentials. Of course, here neurophysiology will be a little different from which we are using in neurosurgery. Sorry, the brain surgery, craniotomy, because maybe they are not taking care of the this uh, EEG. But usually, if they are using neurophysiology here, so they are also monitoring EEG. Okay, so even inhalational agents they will not allow, because it can affect the evoked potentials. So muscle relaxers, what you will be doing, that you will be using EVA. Okay, so here option will be propofol, okay, fentanyl, and another option will be
Sir,
remifentanil,
Dex mentioned.
remifentanil, okay, dexmedetomidine, and ketamine infusion. lidocaine infusion. Lidocaine is like, you can not properly TIVA, but it is adjunct. Okay. So in TCI, what they do in TCI is target control infusion, in which there are preformed, and there is a special models, Schneider model and Marsh model for some remifentanil, propofol, and fentanyl. I think these two, there are certain limitation for it for some certain age groups. You should know, there is an article I will show you, so you can read. And so because that will be the concept which they can ask you is three compartment model. They can ask you about context sensitive half-life. Okay. So, and that the purpose of the target control infusion pumps, these are just like any syringe pump, but they have target TSCI function. Okay. So they have installed already with the demographic data like age, sex, and gender, and according to population, they will, the purpose is the thing is that they will maintain the blood levels. Okay. So like if you want the blood levels to be increased, you will just change the blood levels, and the pump will automatically give according to the pharmacokinetic of that medication. It will give a bolus, and then it will increase the infusion accordingly to maintain a constant blood levels. So that is the purpose of TCI. Otherwise, it's like a normal syringe pump. Okay. So like they can ask you about the doses. So propofol from 25 to 200 microgram per kg per minute. Okay. Fentanyl 1 to 2 microgram per kg per hour. Remifentanil is in like small dose, 0.5, 0.1 to 0.5 accordingly, according to the scenario. So with the remifentanil, if you stop suddenly, you have to replace it with some replacement analgesia. Otherwise, suddenly there may be opioid-induced hyperalgesia. Okay. So patient can suddenly become, because remifentanil has least duration of context-sensitive half-life. The concept of context sensitive half-life is that when you stop an infusion, okay, in how much time the therapeutic levels are gone. Okay. So the least, because it is metabolized by the plasma esterases, so it will vanish in within 3 to 5 minutes even. Okay. So patient, if you have not replaced some other opioids or some other analgesia, patient can go in sudden hypertension, tachycardia, patient can be in like hypertensive crisis. Okay. So this is dexmedetomidine. Usually we are using like zero point 0.1 to zero point 0.5 microgram per kg per hour, like that. And ketamine infusion also like maybe 0.25 milligram per kg per hour or like that. So, and lidocaine also 1 to 2 milligram per kg per hour. So these are certain like options you can use in TIVA. The concept is that you are not using any medications which are affecting the motor evake potentials and somatosensory work potentials, because this is for the patency of the preservation of the because when they are doing the surgery, it can affect the spinal cord. So they actually, they have to maintain the integrity of the spinal cord. So that's why they are monitoring this ascending and descending tracks. So this is one thing. And then EVA, TCI we discussed. Cell saver also is helping. Yes. So hypotensive anesthesia, you have to think that usually for like you are for brain, you are allowing even up to 60 to 160, like it's a limit. But for kidneys, it is 80 to 180. So here, if you are hypotensive, the patient is hypotensive for a longer time, patient is prone to go in acute renal failure. Okay. Okay. So AKI can occur. So you have to maintain this. This is another thing. And another that, like there are certain different options will be that one will be use of N-acetylcysteine. I have never used N-acetylcysteine in such patients, but this is theoretical, more of theoretical thing. And another, what else? Bleeding.
Regarding,
Yes.
can we use as a diuretics at the end of surgery for urine
Diuretics,
output? The
no,
patient urine
please.
or yes,
Okay, just tell me
diuretics.
one thing. What is the role of diuretics?
Sir, volume to reduce
You
volume overload, sir.
you have some camel or horse, and you are not letting the patient this this the you are not letting the patient having any energy, okay, and you are hitting. So is it a good choice?
No, sir.
Okay, so I don't think so that diuretics is only to make the urine. Yes, you can have a single shot to, but usually you will only do it when you have replaced the fluid status. You have maintained the fluid status. You have correct like all the things which are required, like hemoglobin, hypovolemia, hypoperfusion. You have to, then you can still, if it is not working, then you can may try, but it is not only to create urine. Okay. Yes, Zishan, what's your opinion?
Yes, sir, I think so. We should, if it is not required, we should not just give it to increase the urine volume, but because it can also create electrolyte disturbances associated with
Yes.
its use, sir.
So, okay. So Bilal have mentioned about bite block. I forgot to tell in this scenario because you are not giving any muscle relaxant and they are checking. So bite block is mandatory. Okay. So now to allow to avoid tongue bite even. So this is a very important thing. Yes. Throw LMA convert supraglottic into infraglottic. Okay. Spinal ischemia, AKI. Yes. Okay. So for hypotensive anesthesia, actually the TIVA which you are using, still you can use for hypotensive anesthesia creation as well. Because if you are using propofol in a higher dose, automatically, but if it still it fails, then you can go for like medications like labetalol or nitrates. Like this will be the only if your anesthesia medications you are not able to control the blood pressure. And usually that you should not move more than 20 to 25% of baseline or of the ambulatory readings. Okay, because the reading which you take preoperatively is not a good indicator. Okay, you should see the ward readings, that what is the trends, and then you can go up to 20 to 25% of the baseline. Okay, so this is some important points which I have discussed. Mm, eye injury can occur, tongue bite, fluid warmers. Yes, the best friend: hypothermia, hypotension, hypovolemia, acidosis, hypoxia. These are the things which you should always take care in any patient. Here it will be one more thing which you can say is that you can use some hemodilution before you start. So normovolemic hemodilution or hypervolemic hemodilution. Okay, so you can remove. You see that's what is written here. So this is normovolemic hemodilution in which they are removing the blood. Okay, and then replacing it with the crystalloid or colloid, and then you can use it. Then, as I mentioned, cell saver is another technique. And because in our part of world usually they are not asking, but in the international exam, Jehovah's Witness is something which they can ask, because they will not allow to have blood and blood products. So maybe this technique, maybe they accept it. There are different categories of Jehovah's Witness, but you can say these are the blood conservative strategies. Okay. Hmm, okay. Muscular causes, respiratory function, nerve monitoring. Uh, we have discussed some of
Sir,
it. Yes.
sir, regarding restricted lung disease, ventilation strategies.
You have to take care of the airway pressures, because
Okay, sir.
airway pressures can go up. So pressure control ventilation will be a better choice. Some people will say that you can use up to 0.5 Mach, but it depends. You will discuss with the neurophysiology team what they want. Okay. So the rest of the things are the same for whether it is a brain surgery or spine surgery, or whether it is scoliosis surgery. A little difference is in that only for the EEG monitoring and use of this inhalational agent. So you can say that you can use up to 0.5 Mach, but you will discuss with the surgeon and you will discuss with the neurophysiology team what they want. Okay. So they have written here hypoxia, hypercarbia, hypothermia, hypotension. These are my best friend. Wake up test. Unfortunately, because I have never done in my life, and now it is obsolete, but they will ask you. So what you will, the basic thing is that you will be using the same mechanism. And now you have explained the patient about they will intraoperatively, they will reduce the anesthesia depth, and they will ask the patient to give they will give the command, or maybe that you have to hold the hand tightly or you have to move the limbs like that. But I'm sorry, I don't have much to say about this wake up test, because it's unfair to ask this question in 2025. This is history, and I don't know why people don't move forward and they are still asking the things which is practically, it's a crap technique. Patient can the what are the problems in wake up test? Patient can move, patient can injure something, patient tube can be dislodged. Like there are so many things which can occur. So in my opinion, this is a crap technique, but still they are asking a buyer's block in exam, which is obsolete. This is an obsolete technique. This is a totally rubbish technique now when you have ultrasound, and it's a very dangerous block. But still people are they are doing it and they are asking in the exam. I don't know why they kick out this question, but still they are asking. So a wake up test is also is an insult for me. I am using a little hard words, but this is an insult to be asked in the exam. But you should be knowing. So I don't. I think this is the thing which you can do in wake up test. Okay. So okay. So you can have they can ask you about different if drugs effect on somatosensory and motor evoke potentials. You can see nitrous oxide is also have the effects. So benzodiazepine has less effect, propofol less effect. Anyways, so fentanyl, remifentanil has no effect. So post-operative complications, respiratory problems can occur, atelectasis, hypoventilation, secretion irritation. This is can occur in any patient undergoing. So you should be giving a very good analgesia. Okay. So multimodal analgesia plan, you can see all in all patients. In my previous few sessions, I did not use the word gabapentin, but the gabapentin also has a sparing or opioid sparing effect. I forgot to mention in my last discussions. I did not it just come out of my mind. Okay, so that's what I was telling you, post-operative visual loss. So it can occur because this in this tutorial they are discussing in pediatric, but this can occur. We can discuss with reference to adults, especially if the patient is hypertensive or diabetic or any cause of like pre-operative patient has any retinopathy. So that patient will be more prone. Here what is the it occurs in two distinct forms: ischemic optic neuropathy and central retinal artery occlusion. ION may be anterior ischemia of optic nerve near orbit or posterior ischemia of optic tract towards the occiput, with posterior ION occurring 3 times as frequently. Posterior is more common. ION associated with blood loss. Okay. Uh, Operating time lasting more than 6 hours. Preoperative anemia, intraoperative hypotension, intraoperative hematocrit less than, so almost the same things. One thing which is not written, I'm not sure about it, but I think I have read somewhere. It's not, I was expecting it to be here, but uh, tranexamic acid is also one of the triggering factor. Occurs from direct compression of eye, causing retinal ischemia. Any direct person must be avoided. Central retinal artery occlusion. Okay. Mm, so I think this is the thing. Specialized Allen table. As I was telling you, this was the name of the table which I was telling you. With a chest pad, high pad, a hip pad, thigh pad, head support, leg supports, arranged on a frame is used. There is a special. Okay. Mm, Sometimes they are giving paravertebral block also for this surgery. We will just have a look. Uh, Okay, Zishan, anything you need to add?
I
Bilal,
think, sir, we have covered it.
Bilal, if you can just add anything which we missed. So this is, you see, possible etiologies: idiopathic, neuromuscular, the cerebral palsy, myopathies, polio, syringomalia, Frederick's ataxia, congenital anomalies, traumatic, okay, syndromes like Marfan syndrome, rheumatoid arthritis, association with the, I think, malignant hyperthermia also. Investigations, chest X-ray, pulmonary, ABGs. ABGs I did not say. So if there is any involvement of pulmonary system, then echo also you can do. Otherwise, the normal, because the patient is at risk of renal, so you should have a baseline creatinine. Okay, and electrolytes. So I think that's it for scoliosis. For any blood conservative strategies, you have to monitor this allowable blood loss and how will you replace it. And these are they have written here. Okay, because we discussed in our last sessions, we discussed about blood conservative strategies. Wake up as you see, they have what they have written: surgery is halted, the volatile agent switched off, and emergence allowed. The patient is asked to move their feet, and once this occurs, anesthesia can be recommenced. Assistance is needed to prevent patient movements which can cause accidental extubation or loss of vascular cannulas. In the event of new paraplegia, all implants should be removed. Hypotension and anemia corrected in a course of high dose methylprednisolone steroids for neuro injury and neurological better recovery. Okay. Okay.
ये लो इसके ऊपर रख के करो.
Okay. So,
Excuse me,
yes,
should we get pulmonary function test done every patient?
pulmonary function test, uh, depends on the etiology. But usually as a baseline, pulmonary function tests are being done because in scoliosis, even if idiopathic scoliosis is developed, it can affect in some way the pulmonary functions. So I think it is like it's majority of patient pulmonary function test will be done. What's your point? What do you think? Yes, Dr. Hani.
Sir, जी sir, I think in every patient it should be done, but the patients with decreased functional capacity, it should be done
Yeah,
in
remember
both.
one thing yes, you are absolutely right. Actually, the thing is that if you in the exam, there will be one option will be in, for example, MCQs part, you will have some option by which you will pick it. In oral exam, actually, if you commit, you can use some words to defend it. So if you want to defend this test, you can defend in this way, as I have mentioned. Okay.
Okay, sir, thank you.
So the next part, which uh, like you can find here a lot of information about scoliosis. So the next topic which I wanted to discuss today is hip surgery. Okay. So usually the number of concerns which we have discussed as any orthopedic surgery or with reference to bleeding. So a number of things are the same, but here some extra points we will think that whenever you have a hip fracture, of course, trauma can occur in any age group, but usually you will have an elderly patient who fell down and have hip fracture. Okay, so this is one group. Then any patient with osteoporosis can have hip fracture. There are certain things in which there is they are replacing the hip joint for example, as occur in ankylosing spondylitis. Okay, so it can so they are replacing the joint, that is joint, like you can say hip replacement, that is a little different. I'm talking about hip fractures. Okay, so this is one thing. And then another will be any patient with any bone metastasis or primary bone tumor. So tumors will be another category in which there may be fracture. So whenever they are talking, so you have to think about these 2-3 things. Trauma, of course, as I told you, that trauma will be there everywhere. So elderly patient, Zishan, can you quickly tell anesthesia concern in an elderly patient?
The anesthesia concern in the elderly patient in altered anatomical, physiological, and pharmacological concerns which will alter our anesthesia technique. Like, in the form of difficult airway in this patient, early desaturation, and difficult positioning in this patient, uh, increased risk of thromboembolism, increased risk of dementia, increased risk of post-op pain, increased
Difficult
risk
IV line.
of difficult IV lines, sir, increased risk of mm, uh,
You said
post
postoperative delirium.
yes, sir, post-operative delirium, sir.
So you can just you
And
can just organize that because of altered physiological, pharmacological, and anatomical consideration, there is challenging anesthesia conduct with reference to preoperative evaluation because there are more chances of comorbidities in this age group. And then, like certain things as you mentioned, you can divide it into airway problems, cardiovascular problems, and then problems with reference to IV lines and postoperative chances of postoperative delirium, and these are the things. So you can just quickly review. Another important thing, because if you have a patient even with fracture, you have to think, do you have to rule out some other thing, Zishan? If you have a scenario of
sir,
a patient with hip fracture coming for hemiarthroplasty or any surgery for hip fracture, so is anything else you need to rule out?
sir, we should rule out the cause of the fall, whether the patient slept or whether the patient had a syncope episode.
Yes.
We have
So
to rule out the
so
cause.
maybe any neurological, cardiac, pulmonary, okay, and it may be any cause, metabolic, okay. So like you have to rule out whether the patient fell down only by slipping or anything occur. So this is one thing you have to mention in any of such scenario. Okay, very good. So and
And sir,
then yes,
as a Clarkson, mostly patients getting DVD prophylaxis. So
yes,
that scenario regarding this and blood thinners, we should consider if we are going for neuralgia blocks.
yes, yes. It's also important. Just a second. Because there was what I wanted to show you is when will you delay the case? Okay, what factors in which you need more evaluation and you need to delay the surgery. Just a second, this is not practical. What are the there is actually a guideline in which there is yes, okay. So they can ask you because this is from AAGBI. So when you can delay the surgery a little bit, okay. Very low hemoglobin, very low electrolytes, or very high, like significant electrolyte imbalance, uncontrolled diabetes, correctable cardiac arrhythmias with a ventricular rate of more than 120, chest infection with sepsis, reversible coagulopathy. So they can ask you this question, practically how you explained, and this is unacceptable. Unacceptable reason is that lack of facility or theater space, awaiting echo. Because such patients, a number of time, you are not able to assess the physical activity, and but you cannot delay it only to do echo. Unavailable surgical expertise, minor electrolyte imbalance. So this is actually from AAGBI. So you should be knowing it. And then another question you have to answer is that how will you choose between GA versus spinal versus epidural? So in when you discuss this thing, then you will, as Noon mentioned, that because of comorbidities or because of pre-existing problem or because of immobility, a number of time these patients are on anticoagulants or antiplatelets. So you have to consider this thing when you are choosing the choice of anesthesia. Okay, whether you have to choose epidural, spinal or GA. Usually, if there is no contraindication with reference to regional, so regional is always a good choice. Okay, so it is always better to do it with spinal, or for post-operative pain, you can have epidural, or you can give this. What are the blocks which you can give for another question which they can ask you, not only for conduct, even if you are giving spinal or epidural, will it be any challenges, Zishan? Any challenge only to perform central noxal block?
Yes, sir, the patient will have pain, and to set the patient up for spinal patient, there will be a lot of pain to the patient because of a fracture. So we can give any neuraxial block, not neuraxial. We can give a regional block before putting the
What
patient
what are the
on.
options?
We can do 3 in 1, 3 in 1 femoral
Three in
block,
one. Okay, now
block.
3 in 1 is instead of saying 3 in 1, sci-fi block. Suprainguinal fascia iliaca block is a better option. Okay. And another block which can they use for the patient positioning is PANG block, posterior nerve groove block. Okay. So these are two blocks. You can read some details about it. Inguinal sci-fi block is actually because when you are giving, because the hip nerve supplies is not fully covered. If you are giving infrainguinal, it sometimes it does not spread. So this is the reason. We will discuss in details the blocks, and we will discuss something more. Right now, I'm just telling that the telling Bank block and this sci-fi block, or some people use ketamine, small dose of ketamine to do the positioning. So ketamine midazolam is also an option. You will attach the monitoring, you will attach the oxygen, and just to make, you can give lateral position, and you can get some help from ultrasound to mark the target, so that your spinal will become a little easy. Okay, so these are different options you can do for the regional. Epidural is usually, if the surgeon is quick, actually spinal with post-operative pain relief with this sci-fi block or PANG block, you can still say. Otherwise, you can have epidural for like 2 to 3 days for post-operative pain. Okay, so this is another thing, and because you should tell each and everything separately. So that's what I'm telling you. For monitoring, special monitoring, arterial line, you can say that if you are in an age in this patient group, if you are expecting swims of blood pressure, so you can have arterial blood pressure monitoring, urine output, the standard one, standard two monitoring will be there. Okay. So otherwise, maybe you need to do some ABGs if you are expecting any electrolyte changes or things like that. So this is other thing which you need to do. What else? Anything? Fluid management, like you can use fluids. You will target, because if you have any patient with cardiac problem, so you will maintain hemoglobin around 100. Okay, and like 10 gram per DL, and all the blood conservative strategies which you discussed before, you can say. Okay. Mm, what else? They have written also SOAS compartment block, but of course it's not a very common block. But if you are making the list, you have to. Actually, this is a relatively older article. If you will find any new text, you will not find this three nerve block. Okay, you will find this fascia iliaca block, sci-fi, suprainguinal fascia iliaca block. Here you see they are not mentioning sci-fi, but in the latest text you will find sci-fi block. Okay, so thromboprophylaxis, antibiotic, pressure care, thermoregulation, intravenous fluid, judicious, or you can say you have to avoid hypovolemia. Okay? Nursing, analgesia, hypoxia, fluid balance, UTI, because a number of time they are not moving. Okay, so they need to have a number of time. One of the reason for this is urinary retention with spinal. So maybe you need to have Foley's for some time, but you should be removing it at the earliest possible time. Okay, so what are the factors? Another question now. What are the factors which will prone the patient for postoperative delirium? Yes, Zishan or any other exam candidate or Hani. Dr. Hani is here. You want to tell, please? Anyone wants to speak out, just raise the hand. So if you want to, anyone wants to answer this question, what are the factors in perioperative care which will predispose the patient for postoperative delirium?
Sir, if starting from the pre-operative, the patient presented with severe pain, and pre-op pain is one of the concern, and then coming to the anesthesia factors, swings of blood pressure, hypotension, hypercarbia in the intra-op, this can lead to uh, post-op delirium.
Hypothermia.
Use of hypothermia. This, yes, sir. And prolonged surgery time is surgical factor, prolonged surgery time, prolonged tourniquet time, use of
Electrolyte, electrolyte
electrolyte
imbalance.
imbalances. Yes, sir. Uh, and then anesthesia factor, use of uh, they say use of midazolam can
Use of
benzodiazepine can also
midazolam.
cause post-op delirium. Yes, sir.
Yes. So which will be a
And
better choice for anxiolysis? Either you
sir,
use
Dex.
diazepam, either you use diazepam or you use dexmedetomidine
Yes.
or propofol. Okay, for if you want to give some, because sedation, conscious sedation or sedation alongside regional is used a number of times. Okay, so Presidex with propofol or diazepam will be a better choice as compared to midazolam because of short acting. So suddenly the midazolam effect will finish and patient can become very aggressive. And small dose of ketamine, doses of ketamine. Okay. Actually, if you are answering, you don't tell these the uncommon things to start with. If they are asking you more and more and more, then you use this word ketamine, because ketamine is definitely a factor. If you are using in a small dose, it is prevention for delirium. But please use this answer tactfully, okay? Because maybe some examiner will not agree to it, because you can say in some text it's not written. And traditionally, whenever you are saying ketamine, traditionally we are thinking that ketamine will cause hallucination. But actually, if you are using in a multimodal analgesia, if you are using in a part of anesthesia, actually ketamine is a miraculous medication. I use it in almost every patient. I'm using a small. I used to say that this is a background music. So this is a background music behind which you are doing a lot of things. It will reduce the doses of induction agent. It will reduce the uses of opioids. So there are so many advantages of ketamine. If you are using it tactfully, I don't think so. There is any, but you cannot mention this thing in exam. This is a practical advice to all of you, that ketamine is a darling medication. I love it. Okay, I use it all more, but of course, don't use it in high doses, because the same thing like Presidex. Presidex is also a medication. If you use tactfully, it's a wonderful medication. But if you are using it in high dose without any understanding, a predetermined dose according to the weight, Presidex can create a terrible things for you. So Presidex, if used tactfully, is a wonderful medication. So is ketamine. Okay. So actually, here we, because we were discussing about, so I forgot to mention some words about IV lidocaine. Has any one of you used it? Because now it's being used in a number of setups. It is to blunt the stress response. Okay. Even in abdominal surgeries, they are using it as an alternative. Laparoscopic abdominal surgery, they are using it instead of central neurexal block of number of times. But the thing you just have to take care is any liver problem or kidney problem, its metabolism can be slowed, and gradually maybe you can start at a dose of around 2 milligram per kg per hour, and gradually as the stress of surgery will be going down, so you can gradually reduce the dose. Okay, and you will be ready for any signs of toxicity. if it occurs, or you should have, whenever you are using IV lidocaine, you should have intralipid nearby you. Okay, so that if you are using in a higher dose, you should be like this thing you should be in your mind that intralipid may be used, may be required. So like IV, again, like IV lidocaine infusion is also something you can mention, but mention with a little bit of use this answer with a little bit of care again, because maybe some examiners will not be using it, so may they become offended. So if you are this should not be the first thing. Okay, if they are asking more, that recently there is also a growing trend of use of IV lidocaine, but whenever you're using it, you have to take care of these things. So if you will answer this thing in this way, nobody will ask you anything. Okay, but if you are saying I will use IV lidocaine, so maybe they can catch you. Okay, so that is because a number of times even magnesium is used for stress response blunting. So again, for magnesium, it's the same thing, that if you are using magnesium carefully, there is no problem. But if you are using magnesium, neuromuscular blocking effect can be increased. There may be toxicity with reference to respiratory, cardiac, or arrhythmias, or deep tendon, or these things. You should be thinking that whenever you are using magnesium sulfate, because a number of time if you are using magnesium and there is hypoperfusion and renal urine output is not, kidneys are not making enough urine because of hypoperfusion, and now you are using magnesium sulfate, unfortunately it can create problem. So answering in viva is a tactful thing. Okay, so always be careful when you are answering this. Okay, so we will just try to think anything missing about hip surgery. So the patient group population, okay, the concerns, the bleeding, another thing is that usually a number of orthopedic surgeries you can have tourniquet, and but in unfortunately in hip surgeries you cannot use tourniquet. Okay, so this is something you have to take care, and then concerns related to the reason how it fracture occur. In one of the article there was actually the this one written. I will just show you. uh, I think it will be somewhere in some of the not in here. For severe perioperative management, reduce confusion, pain, and aesthetic requirement, reduce respiratory complication, assistant position for nasal exhalation. This is something else you can tell for regional peripheral nerve blocks for hip surgery. Okay, I wanted to show you something because so types of hip fractures. Okay, just that which type of hip fractures are more dangerous. I think this is the same thing which we were discussing before. So you can say that multidisciplinary team, anesthetist, orthopedic surgeon, medical physicians, geriatrician. Your geriatrician is the one which is for this, just like pediatrician, these are geriatrician for elderly patients. Okay, nursing staff, physiotherapists, occupational therapists, social work of use. In our setup, these things will not be possible. I will find it. Any other thing which I have missed?
Yes, sir. Sir, concern related to bone cement discussion with the surgeon.
Very good. Bone
Use of
cement. Yes. So bone cement syndrome, what is bone implantations syndrome?
Sir, for introp, sometimes in the neck fracture neck of femur, the surgeon uses this cement methacrylate to fix the joint, sir, the metallic
Okay.
joint, sir. So while fixing this, some this exothermic reaction can take place, and the particles of that cement can enter the blood circulation, and they can cause hypoxia, hypercarbia, decreased SVR, stress on the heart. So we have to be very careful when the bone is being inserted, and we have to be with in discussion with the surgeon when he's inserting the. So we have to be extra vigilant uh, during that step of the surgery, sir.
Okay, very good. So what are the factors by which you can avoid or reduce the chances?
Sir, we have to maintain the hemodynamically stability before the bone inserted. We have to to maintain the normovolemia of the patient, and we have to we have to prevent hypoxia, give 100% oxygen at that time to the patient. Uh, uh, and so if we simply maintain the hemodynamic stability of the patient, so our risk for cement would be very less.
So I know that this is a silly answer, but you will say that you will any patient who is at risk of complication, you will say that you will discuss with the surgeon that can we use a cementless implant. Okay. So use of cementless implant will be one answer you have to tell. Okay, this is one thing, and rest you have to you has to be in close communication. So before when this insert when you use it, before that try to keep the patient hypovolemic, sorry, euvolemic and euvolumic, sorry, normotension at that time. So if it occurs before that, if you did not correct and then it occurs, so then it's you see that's some of the risk factor they have written here. High ASA grade, COPD, use of diuretics, use of warfarin, okay, and then increasing age. So these are the things which they are uh, they are because then in this topic they have uh, told this one. So they have made this some more details. Identify cases requiring cemented hips. Discuss the need of increasing monitoring, discuss appropriate cementing technique, because there are certain, not especially in this one, whenever, so they can do retrograde. So retrograde, the pressure is not increase as much. So sometime, and they can have a hole. So it is vented. Okay. So this is one option they use it. Okay. Maybe you will find here. So they have written some. So actually, this is the tutorial is specifically on this topic. So there are certain things we will do. Yeah, that's what I was telling you. Okay. Uh, Inform the anesthetist prior to cement application from the surgical. Wash and dry the femoral canal. Apply cement retrograde. Okay. Use a suction catheter and intramedullary plug in the femoral shaft. Avoid excessive I don't know pre-suturization. I don't know what it. Maybe it is reaming, something like that. I'm not sure about it. Adequate hypohemodynamic optimization, systolic blood pressure within 20% of pre-induction value, proper vasopressor in case of cardiovascular collapse, confirm awareness that cement is about to be prepared or applied, maintain vigilance for cardio. That's what we always already discussed. Okay. So you see, lavage of femoral canal prior to cement insertion, high pressure, high volume, pulsatile lavage, brushing and drying of intramedullary canal of the femoral shaft before cementation, use of a suction catheter to depressurize the intramedullary canal using a bone vacuum technique, mixing cement in a vacuum and using a retrograde cement reduction. So these are the things which they can ask you. And if it occurs, airway, breathing, circulation, and all the common thing which you have to tell. Fluid will give fluid, you will give, you might need to give vasopressors. And okay, so in this, prevention is better than cure. Okay, so that is, so Pang block, it has come in front, so we can have few words about it. So high articular branches from the femoral nerve and accessory obturator nerves are consistently found between the AIS, anterior inferior iliac spine, and iliopubic eminence. The obturator located close to the inframaterial. So is the innovative single shot technique performed under ultrasound guidance to specifically block these articular branches. Okay, so you can have this. This is actually the Pang block. So femoral nerve, femoral artery, femoral vein. This is iliopectineal eminence. I have done few times. It's a relatively difficult block as compared to fascia iliaca block. Okay, any block in which you have to go deep and you can pass through some structures, that becomes a little difficult. But it is easy in that aspect that you have a endpoint, a bony endpoint. So, and of course, any block, if you are using carefully, is good. Okay. So here they have. So I think Bone cement, yes, I was missing. Fat embolism also. So fat embolism is also can occur in any orthopedic. So how will you manage fat embolism? What is fat embolism? We can discuss this topic here also. Yes, Ishan.
Sir, fat embolism syndrome is a clinical condition which happens which commonly happens after a fracture of the long bones, and in which the fat droplets can get introduction into the blood vessels, and they can initiate a cascade of reaction and mimicking an anaphylactoid reaction. And they can also, one, they can start mimicking an anaphylactoid reaction, and another, they can go to the pulmonary circulation and can obstruct the right ventricular outflow. So they can have
Okay, so
symptoms of decreased cardiac output from this side.
yes, actually they can ask you these criterias. So fat will be there everywhere. So there is this GERD criteria, major criteria in which there is axillary or subconjunctival fatigue, hypoxemia, CNS depression, disproportionate to hypoxemia. Okay. And pulmonary edema. And minor criteria is tachycardia, pyrexia, emboli present in retina or fundoscopy, fat present in urine, a sudden inexplicable drop in hematocrit or platelets values, increasing ESR, fat globulus. So they can ask you these criteria. This is another criteria. But actually, as you mentioned, that these are the patients which will be at risk. Like hip fracture is one of the major uh, thing associated with fat embolism. Okay. And there's certain, yes, tell me one thing, any other surgery other than orthopedic in which fat embolism can occur? Can you tell me? Any one of you?
Or obstructive surgery.
Obstetric surgery? No.
Liposuction.
Sir, liposuction.
You are late, Zishan.
Thank you,
Hani
sir.
has one, Hani, Electra for Hani. Okay. So liposuction. Okay. In liposuction, fat embolism can occur. So rest of the answer is the same: airway, breathing, circulation, evaluation, management, resuscitation, evaluation, and management will go side by side, and rest of the things you can tell. Usually, it is subacute as compared to massive thromboembolism. Okay, usually fat embolism and amniotic fluid embolism is relatively subacute or maybe subacute as compared to air embolism and massive thromboembolism. Okay. So, and this is and one thing, and both of fat embolism and amniotic fluid embolism have immunological etiology as well, in addition to the obstructive etiology. Okay. So this is what they have written here also. Mechanical theory, or maybe they have written here also the this biochemical. Okay. So production of toxic intermediate of fat present in plasma or mechanical obstruction. Okay. So I hope we have discussed. Maybe you will have find some new article about it. Maybe something new because this is also relatively old article. So maybe here we can have a look. Mm, So you see the thing, the people, if any one of you among you juniors who are listening to discussion, believe me now, because of course when I started my training, we did not, nobody used to tell us that there are some articles or there are something other than that Manhus Morgan. Okay. So just tell me honestly, just think honestly. Does study be covered with Morgan? Think yourself. Okay. So I really believe me now. I have not read these articles, believe me. Because even when I appeared in Irish fellowship exam, I read some of them, but during my FCPS, I had no idea whatsoever about these articles because nobody told me. And this internet and these things and smart soft copies were not available at that time. Okay, so you people are very lucky that you have idea. And today, if even if you are following what we used to follow 20 years ago, unfortunately, you are very unlucky. Okay, so I will highly suggest you to wake up. This is not an era of reading any topic with one book. This is era of smart studies. So topic oriented study is more important than book oriented study. Like you see from where we started, just imagine, even in hip surgery, there may be a differential diagnosis of unconsciousness, syncope. There is a differential diagnosis of what are the various types of fractures. I still did not find that article actually. That there are certain hip fractures. Just a second, I will show you because before I forgot. Uh, because in hip fracture, I think it's here because I'm
Sir, I know a little bit about it. Can I tell you?
because actually you know what, there are different types, subcapital or cap, which fracture is more dangerous.
Yes, sir. The one which is inside the capsule,
I think it is
it
here.
will have less,
Is less what?
which is like there is one is subcapital, and then there is trans cervical, and then there is intertrochanteric, and then there is subtrochanteric, sir. So if the suboccipital and transcervical, which is inside the capsule, so it will have less blood loss. Uh,
Yes.
uh, uh,
So you, that's what, so here, that was the picture which I was trying to find out. Okay. So intracapsular and extra, so intracapsular will have less blood loss. Am I right?
yes, sir.
So blood loss from cancellous bone is greater, such that the total blood loss from an extracapular may exceed 1 liter. Okay. So the greater the degree of combination, the larger the bone fragments. Okay. So this is another thing that hip fracture or femur, neck or femur fracture, these patients can have even up to more than 1 to 1.5 liter of blood loss. Okay. So these questions they can ask you in the exam. So you see so much dimensions. So cell salvage they can ask you, regional anesthesia they can ask you, how to make the positioning of the patient, differential diagnosis of how the patient fell down or so. I hope I have just tried to give you an overview of this topic. Anything missing? Because I have discussed this topic a number of time before as well. So I will just show you here. So because this is a very, very important topic. So do read about it. I think you will find it here. Rheumatoid we discuss. This is orthopedic anesthesia. You do listen to it. You will find here elderly patient for fracture of femur surgery. Okay. So in this topic we have discussed. So scoliosis I have discussed before. Rheumatoid arthritis we have discussed before. Okay. So please have a look at it, and inshallah, we'll just try to continue our top and discussion. We'll try to cover some of uh, main scoliosis we have discussed, rheumatoid arthritis we have discussed. I think we can have knee surgery, shoulder surgery. Okay. So let's see. Okay. So thank you very much for your time, and inshallah, we will discuss further. Okay. Dr. Hani, I think I hope you get benefit. Anyone who have any answer, you are welcome
Thank you, sir.
anytime. Okay. Bye bye.
Mm. Thank you.
Thank you, sir.
Assalamu alaikum.